First of all, I would like to thank you for this opportunity of speaking here with this great audience of experts. And what I'm going to talk about today is about the costing the cancer care pathway and how this information and the new data on population-based data set can be used for informing research in England. I would also want to thank the sponsors and partners in this project that is an ongoing project with Macmillan Cancer Support, the NCIN, Imperial College and City University. Okay, so a quick overview of what I'm going to speak today. First of all, I'm going to talk about building this new data set where we linked information on patient records from the English Cancer Registry with data on hospital utilization and cost. And then also we're going to test, I want to show you some descriptive statistics coming out from this data set. These are very basic descriptive statistics, and they are like preliminary results, and we're not want to use these as a base for making inference on policy or resource allocation, but just to show what are some of the potential, the information that can be extracted by using this new data set. Okay. So some of the motivation for this type of work, well, of course, like the cost of cancer is soaring because of different drivers like aging population, improving cancer survivals, and increasing cost of care. And so under this context, having population-based data are important on the care pathways, are very important to allow for monitoring the present costs. So what are the main drivers of the actual costs, to plan future expenditures, and also to design effective health policies. For example, how to reduce cost but without affecting health outcomes, or how to improve health outcomes without having an impact on costs. Also, it can be like an important tool for making policy decisions about resource allocation and budget allocation across different health programs. Okay. Another source of motivations is the lack of evidence on the cost of cancer in England. So we have, there are little evidence about what are the direct costs of cancer, and also on what are the main drivers of those costs, or technology, demographics, or variation in medical practice, or patient preferences. Most of the evidence in England comes from cost-benefit analysis in clinical trials, which have a number of advantages. For example, the variability of accurate micro-costs on patient characteristics and treatment characteristics through the collection of primary data, but also come with a number of limitations. For example, the external validity of the results. Often clinical trials have a constraint in sample size and follow-up, and the study setting so is restricted to a small number of healthcare providers. And this led to the fact that the results are not often replicable or observable under real settings. So also clinical trials often focus on just one part of the care pathways, leaving like the rest of the pathways like for a separate study. So it doesn't provide a full picture on what is the treatment pathways of cancer patient. I would like to also quickly remark like lessons from the US that we have heard from Robin. I mean, in the US, the linkage between of a population data set based on the population of patients diagnosed with cancer, and has been linked with the insurance claims. So we have the SEER Medicare data set that has been like built in '99. This is a tremendous resource for doing research with more than 1.5 million patient and hospital care utilization cost linked. And it's been used, this resource has been used through, for a number of publications for informing like the economics of cancer care, and we have like very interesting like publications in top journal in the field. So far, we don't have an equivalent resource for England, and my job here is basically to like trying to get to the point in which we have a similar resource for research in England. Okay. So some of the evidence, I would like to go through at least a couple of works that have been trying to inform like the literature on what are like the impact and the relationship between cost of care and health outcomes for cancer patients. So here is a study from Martin and colleagues from the University of York, where they investigate the effect of healthcare expenditure on health outcomes using aggregated data on the level of the health commissioners. So they have examined whether like local health commissioners that spend more on cancer programs have then return in terms of better health outcomes for their population. And in this study, the challenge is, of course, that the association between expenditure and outcomes might be underestimated due to endogeneity, in terms that more spending, yes, improve health outcomes, but also poor health outcomes attract more spending because of higher needs of the population. So these two opposite trends may cancel out, and so we might have observed like a zero relationship between spending and health outcomes. So the authors use an instrumental variable approach for disentangling these two effects. And after they use their sophisticated statistical models, they found that an increase of 10% in the expenditure in cancer programs leads to a 5% reduction in mortality from cancer. Another studies that I would like to describe here is from Bending et al. Is a collaboration between the University of York, the University of Sheffield, where they try to estimate the direct cost of bowel cancers in England. So what they use is a pathway model that describes all the possible options for individual at each stage of the cancer. The alternative pathways are not observed from the data, but are derived from clinical advice. And then the model is populated using evidence from existing literature and average utilization, average data on utilization from hospital episode statistics and reference costs. And using these methods, the authors found that bowel cancer is in excess of 1 billion pounds in 2005, and 35% of this cost is absorbed by testing patients with suspected bowel cancer, and then turns to be actually negative, not having the disease. So I'm taking these two examples just for like describing what are the space for future research and what are the limitations of the research that is currently we are currently able to carry out with the data that are available. So in Martin and colleagues, they use aggregate data at the level of healthcare commissioners. So this limits the investigation on the mechanism that explain the relationship between more spending and better health outcomes. And this could be disentangled if we had microdata at the level of patient. Also, the identification is obtained through cross-section. So we are observing like expenditure and outcomes only in 1 year of data. In Bending et al., the predicted cost is based on aggregate pathways. And the pathway model is actually derived through clinical advice rather than being observed from the data. And so we miss all the variation in cost that is generated by variation in pathways through different areas. And also the identification is obtained in a cross-section of data. So in this context, the availability of population-based data on healthcare utilization and cost can advance dramatically, I think, the empirical research on the cost of cancer care. So some of the sources of population-based data for England, there are at least three three big data sets. They are administrative, data-based, and we have exploited these three data sets to construct this linkage between patient diagnosed with cancer and the utilization of hospital services and the cost of the services. So one is the National Cancer Data Repository, known as NCDR. The other one is the Hospital Episode Statistics, known as HES. And finally, the national schedules of reference costs. And I'm going to talk about each of these three sources. Okay. So the National Cancer Data Repository collects patient with, okay, so it collects the registration of patient at the time of the cancer diagnosis in England, and there's a number of different registries that take care of different regions in England, and they collect information about the cancer site, staging and grading, also information about demographic characteristics of the patient, for example, ethnicity, age, sex, and location, patient postcodes. And in the near future, the project is to expand this resource and link this, the registry data with other data sets on the cancer treatment, like, for example, the national radiotherapy data sets, the data set on chemotherapy, and also like a data set on clinical practice research data link, and data from clinical audits. Okay. So the Hospital Episode Statistics is big data sets that collect information on all NHS patients. NHS patients are like basically the patient treated through the through the national healthcare system in England. And they're treated in all hospitals in England, and these include all information about secondary care services through emergency or elective or day cases, and also information about outpatient care, outpatient visits. Yeah. The data are collected at the level of finished consultant episode, that is basically a consultant visit. And so a patient can have, during their hospital stay, a number of different consultant visits with different specialists, and this generates different observations. For giving you like an idea about the size of this data set, it reports 15 million observations each year for inpatient care, and about 50 million observations for outpatient care. It also includes detailed information about the diagnosis of the patient and the procedure that is performed and the outcomes, the health outcomes. And is linked with census data about the area characteristics of the place of residence of the patient. So it potentially can be used for inequality analysis, where the socioeconomic characteristics are identified with the characteristic of the patient area of residence. Okay. So the national schedules of reference cost is the source we have used for costing the healthcare pathways. So in England, all NHS hospitals are mandated to submit information about the cost of the care they provide every year. So this is derived through like a top-down allocation procedures, where the total cost of care is allocated to single services, where each service is grouped through like a system of grouping that is called the HRG system. Is the equivalent of the DRG system in the US. And currently there are more than 1,100 different HRGs. And then there's a distinct cost that is reported for each of these HRG, according to the type of admission, whether it's an elective, an emergency, or a day cases admission, or an outpatient visit. Also, additional costs are reported for a patient who exceed a length of stay threshold. So there's an additional information on cost per day of in-hospital stay. And also additional costs are reported for expensive additional services, like, for example, chemotherapy, radiotherapy, or critical care, and many other like rehabilitations or diagnostic imaging. Right. Now, the achieved outcomes, so this is an ongoing project, and so far we've managed to match the cost of hospital care only for inpatient admissions with utilization of hospital services. So we match 100,000 data records on costs with about 4 million a year in data about in-hospital visits and finished consultant episodes, and then these have been matched with the NCDR, so records about the patient registered at the cancer registry, which are about 180,000 per year. So we used, in the first instance, we used cost reported in 1 year only, 2010, and then we matched this information to utilization occurred from 2006 to 2010. And one of the reasons for doing so is to minimize the artificial variation over time in the cost of each HRG, which is not generated by, for example, technological progress or increment in efficiency, but rather to variation in the accountancy rules that allow the hospitals to allocate total costs to single services. Indeed, the reference costs datasets is it has experienced a number of changes over time, and these are mirroring basically the improvement into the costing procedures through which hospitals allocate their costs to their single services. And this in partially reflect also a change into the policy on reimbursement of hospital services. So in England, we've passed from budget allocation policies where the hospital costs were reimbursed at the end of the year, no matter what type of services were delivered, to payment for performance basis, where the hospital services are reimbursed on the basis of the volume and type of service delivered. And this has been phased in from 2003 to 2008. And through this number of years, hospitals have improved the way they report information about their costs and the cost of the activity that they provide. So this is one of the reasons why we decided to use 1 year of one fixed year for the cost, at least for the first instance of this exercise. And then we match the cost from 2006, and this is also related to the fact that information about the activity and the utilization is available from 2006 can be matched with the information reported on cost, while for earlier years, the procedures, the details of the type of the care provided is not well enough for doing a reasonably good match with the cost reported in 2010. And the linkage is, I think, quite good. We have almost all the observation on utilization linked to cost, and then we link the finished consultant episode into spells of care.